Welcome to The Edge. I'm Sam Grau. Teens face problems every day, but in addition to that, many kids face additional learning and physical problems that aren't addressed in full. But these kids do exist, and their struggles are important to discuss. From learning disabilities like ADHD and dyslexia, to medical concerns like Crohn's and colitis. My hope is that by the time you finish viewing this program, you are both more aware of the struggles that these kids face silently on a day-to-day basis, and how you as a student or you as a parent can help through the school to get accommodations. My guest today is Dr. Amy Gosling, MD, a doctor who works at both Pediatrics South and Children's Hospital. She is a physician specializing in pediatrics and has had almost 40 years of practice in the field after graduating from the University of Rochester School of Medicine and Dentistry. How are you?
I am great.
So I know as a pediatrician that you work a lot with the physical aspects of children, but how much do you get regarding mental, learning disabilities, stuff like that from your job?
Well, I think that's actually the greater part of what we do, because most children are well. And although we do some anticipatory guidance, what I find is that the mental health and the behavior problems and the emotional problems are the things that bother children and young adults every day. So I would say that probably 80% of what we do has to do with either parents' difficulties in this area, children and young adults.
So you would say that the mental aspects of it do affect the physical aspects, and they might even come in for that kind of stuff?
Absolutely. Many mental health issues cause physiologic changes that will cause true disease or true symptoms. And sometimes the children and younger and adults are not really aware of the association, so they will come in because of the physical manifestation that stress or emotional problems cause. Or nowadays people are much more aware of the emotional aspect, depression, anxiety, certainly ADHD, and they'll come in directly for that. So it is very helpful when the parents are more aware that there may be an emotional component. The other thing is also true. If you have a physical problem, it always has an emotional component to it as well because of the consequences of whatever physical problem you have. And you cannot lead or help a child attain good health, a young adult, unless you address both aspects of the problem.
Right. So let's say that a child comes in, he's been sick for a while. You only see the physical problems, but it is your job to then identify what the mental problems are. But are you then able to prescribe medications for the mental issues, or are you only able to do it for physical?
No, but I think that you're putting the cart before the horse. If somebody has a physical problem, we're going to obviously investigate what it is and try to figure out how we can either ameliorate it or fix it to get them back to good health. Then the mental health aspect of things has often to do with either physiologic changes, for instance, somebody who gets an ulcer, gastritis, or reflux because of stress. So that will take direct medical intervention as well as changes in diet and attitude. But if somebody is having a secondary or an adjustment reaction, an emotional problem, the first response is not medication. It's to give them other tools to deal with the emotional distress and the consequences of that they're experiencing. So we never do medication alone.
So like you just said, you don't ever do medication alone. So originally you would prescribe therapy or situations like that. Are you the one who then reaches out to find those therapists, or do you say you need a therapist, you should go look for one?
That's a good question, because many people have initials after their names. So the education differs, but what's even more important is the fit between the therapist and the young adult that I'm seeing. Because it doesn't matter what initials, if you don't click with them, you're not going to open up, you're going to shut down, and it'll be absolutely meaningless. So I do have therapists, counselors that I've worked with for a long time, and I know them, and then I try to match up who is going to be a good therapist geographically, gender-wise, for the individual that I'm seeing. And then usually what will happen is we'll start the therapy and they will sign permission so that the therapist can talk with me, and together it's a team decision. It's the young adult is in on it, the parent is in on it, the psychologist or therapist, and then I'm in on it too. So I work in concert with them. And sometimes if they don't get what I call out of the hole, meaning they're totally miserable and the therapy is not bringing things along, then we'll talk about adding medication in at that point as adjunctive therapy, and I will do that.
So you do prescribe those. Okay. Do you work with the therapist in order to create the diagnosis, or is that something that you do on your own and then allow the therapist to work with the patient who has that diagnosis?
There are specific criteria for most of the mental health and emotional diagnoses, and they're put out by the Diagnostic and Statistical Manual of Mental Disorders, which comes out about every 10 to 15 years as a group of psychiatrists gets together and tries to come up with common symptoms. And the intent of that is to try to group kids so that they can study what's going to be an effective therapy. But I tell you, I never really do a checklist. Because anything in the checklist, an individual will have more of one symptom and less of another. So for me, it has to do with how something is affecting their functioning and how severe they are. So I can give the diagnosis, there's no question about that. And I usually refer them to the therapist with a certain diagnosis in mind. But therapy, there are different types of therapy. So there's cognitive behavioral therapy, there's different therapy for reactive disorders, for post-traumatic stress disorders. So, that's not my specialty, but I try to refer them to a therapist who I know is comfortable and proficient in those areas. But the diagnosis is further refined by the therapist that I refer them to.
Now, you said diagnosis. When you say that, I know for a fact that schools are able to administer tests through the guidance office in order to, I guess, diagnose what it may be, whether it's ADHD or dyslexia or some other issue. Is that the same thing that you're doing, or is that something else?
Different. It's an interesting dichotomy here because you have in 1975 the Individuals with Disabilities Act, which provides that all children, all individuals, get a appropriate education. But the criteria to get help, which would be like an IEP under that, are very specific criteria depending on what the diagnosis is. But they exclude medical conditions. Even ADHD is can be either an IEP or what's called a 504 service agreement. The Individuals with Disabilities Act is actually a federal law. And therefore, the schools get some funding and some support, and there are very strict criteria about identification and what they can do. So that's where somebody would get a psychoeducational evaluation by the certified school psychologist to determine if they meet criteria for learning disabilities or for giftedness or for something along those lines. But things like ADHD or mood disturbances or autism spectrum disorder, these are medical other diagnoses, and it goes through the arm of a different sort of evaluation, which is not quite as strict. The other thing about a 504 service agreement, which these individuals get, is that the schools get no federal government funding for it, and that they have to come up with modifications and accommodations. Because the whole idea is to try to look at what's preventing a young person from learning and performing and functioning in activities, and to provide them the support, but also within the context of the minimum support to allow them to perform in the mainstream classroom setting.
Okay. So you said that the school psychiatrist is the one who administers these tests.
Psychologist, excuse me.
Psychologist, yes. So once the test has been administered, what criteria or how do they get graded on it in order to then receive the accommodations or the 504?
Okay, we'll do two different things. The school psychologist is going to do the IEP and the Individuals with Disabilities Act. So they will administer an IQ test, which has a variety of different subtests where they can look at the pattern of that and also what they are. And then you get a performance and a verbal, and you get a full scale IQ. They will then perform some achievement tests to see where you come out with what you're learning. And if there's a discrepancy between your potential as related to your IQ and where your performance is, you have to have a certain discrepancy before you meet criteria, for instance, for a learning disability. But they also look at why. So they look at a great deal of processing issues, auditory processing, visual processing, to take a look at what lends itself to the gap between the two so that they know where they can provide support. The psychologist will grade it, and then they will have a meeting with the parents, and they'll come up with a plan, but nothing can be implemented under a IEP unless the parents agree and sign permission for it. Now, the same is not true of the 504 service agreement. They have to inform the parent, but the parent does not have to agree if it's placing that child or other children at risk, for instance.
So it seems like an IEP and a 504 are different things. I mean, you just said they were. One, a parent needs permission you need parent permission in order to get it, and one the school is just able to administer. So what's the difference between them that makes one need parent permission?
It has to do with the needs of the child versus the school population as a whole. And I'm not a psychologist. Probably you should talk to them about that. From my perspective, what usually happens is I have a very bright young individual whose grades are going down because of a mood disturbance, and they're preoccupied by depression or anxiety. And we always want to make sure that there is not a coexisting learning problem as well as an emotional problem. If I have somebody who has depression, anxiety, mood disturbance, about 30% of the time they're going to have something else going on. And you cannot address one without addressing the other. So the psychoeducational evaluation is done to make sure that there are no unmet educational needs, to make sure that the individual has as much educational support that they need in the classroom to succeed. And then we need to look at the other piece of it as well.
So I guess going beyond medication, what other, accommodations within the 504 or the IEP can be offered to these kids?
Yeah, it depends on the school district. There is now counseling available in many of the schools beyond the school guidance counselor. While they don't do therapy, they may do extra time for tests, do it in a quieter setting. If somebody has anxiety related to performance, they may have an individual not have to take more than one exam on a day, to take incompletes and stretch it out. So what they're trying to do is to decrease the triggers that might increase the anxiety that is interfering in the performance of that individual.
And how long would it take to get one of these after the process of testing?
If you have a 504 service agreement, I can get the process rolling even before they see the psychologist, all right, because I can give the diagnosis. So we always want to have therapy going along with accommodations at school, but only if it's interfering in their performance, okay? If somebody is anxious but shutting it in and there's no problems at school, then we also want to be cautious here because we don't want to make that individual feel more isolated or different than anybody else. It's a fine line.
Right, I was just about to say, in a situation where they might have high anxiety or social anxiety, wouldn't making it so that they only have to take one test per day in a situation where they'd have to make up tests later on a bigger problem?
It can. It can. I know you're going to get to that in the further questions, but this is all about the health and well-being of the individual. So it cannot be a cookbook thing. And I try to have the young adult be in on this discussion about what would be acceptable to them, because I don't want to do anything for them because I can make the problem worse.
So there's extended time, there's for testing. Does it also apply to standardized testing?
Yes, yes. You can get extended time for standardized testing, but they have tightened that up because, as you know, a lot of people abuse that to get extra time to give them the edge. So you need to have accommodations for 3 months prior to the testing, and you have to have had support in place. You can't get to your junior year and say, oh, I got ADHD, I need extra time on my tests.
Right. So you have to go through the school psychologist, and then do you work with your guidance counselor after that? I would imagine you'd have to in order to.
It's a team, all right? So after the testing is done, they have a team meeting with the parents, the school psychologists, the special education, the teachers, the principals, and then they have the parents come in, and usually the individual will be there as well to go over the results and then to be in the planning process. And then they come up with the recommendations, and the parents have a chance to review it and see if they agree or don't agree and sign off on it.
Now, I know you also work at Children's Hospital some of the time. What sort of accommodations do you have for children who were out of school for an extended amount of time? Are they allowed to bring in?
Well, we no longer work at any of the hospitals because Pittsburgh is working towards a hospitalist model where they have in-house hospitalists who take care of the patients that are admitted. Repeat your question again, Sam, I'm sorry.
So there are kids who are have extended time at the hospitals or aren't able to make it to school. Are there accommodations in place for them, or is it really just person to person?
Okay, so it depends on how long we expect that. If somebody's going to be out for an extended period of time, we have the homebound instruction, which is limited educational support. I think the maximum is 8 hours, and it does it for English and for math. So it's not everything, but it will provide some educational support while they are unable to participate and to attend classes. Now, when they go back, the school's goal is to have you graduate and have you learn the material. So certainly they will meet the students and decide what you need to do to make up the work, what you can perhaps take a test and show mastery of, what you need to take extensions for, can you finish it in the summertime. So the goal of the school is really to be the student's advocate. They're not our adversaries in this. So it depends on how sick the person is, how sick they are at home, how much are they able to do the work. So for everyone it's individual, but yes, there will be accommodations even after they go back to school, including partial attendance. You know, go back a couple days a week, go back half days, gradually edge into a full day, things like that.
Now, I know we've been talking a lot about the mental side of it. I'm going to shift over more to the physical.
Sure.
The examples that I used were like Crohn's and colitis. Are there accommodations in place for that situation?
Yes. It depends, not so much on the disease, but it depends on the symptoms. And that may depend on whether they have a flare-up or they're under control. So there would be things written into a 504 service agreement where you could say during a flare-up, this person should be allowed to be late without being marked off, may need to miss school without the parents having to go in front of the magistrate, may need extra time between classes to use the bathroom, may be allowed to leave the classroom at any time, things like that, reasonable accommodations.
And social anxiety can also play into that. I mean, if you have to raise your hand to go to the bathroom
it's
every
horrible.
time. Yeah.
It's,
Other than Crohn's and colitis or inflammatory bowel disorders, what other physical diseases do you see that probably go unnoticed at school every day?
Probably, you're talking about things that aren't obvious, so not a physical disability, and there's a whole variety of them. Things like gastritis or reflux, which may be stress related, so people have terrible pain related to that. Irritable bowel syndrome, where if they get nervous, they have to run to the bathroom and have diarrhea or throw up. You know, that's kind of hard if you're here in school. Cardiac problems, for instance, where they may not be able to have full physical education or they're limited in their physical activity. Again, where it's something internal that's not obvious, and I think those are the hardest.
I would have to agree with you. So you said it seems to be a lot regarding the stomach. What about the combination of both? For example, people who are bulimic or have eating disorders, and they have a mental problem, but they're also physically inclined to have disorders. How do you believe that our school should be able to handle those situations?
They have to work closely with the physicians and the psychologists to see what they need. You know, our goal is control. And if these kids are going to the bathroom and throwing up after every meal, then it's likely that the weight is going to go down and they will need more intensive therapy, which will preclude them from going to school until they're more under control. You know?
If you could change one thing about our school system right now regarding how we accommodate children, what would it have to be?
I actually wouldn't. I think they do a very, very good job. It's a dynamic process. And what I find is they are very open to trying something and then having input and saying, well, this is not really working, we need a little more of that. What we have to struggle with a little bit is to have the individual student seen. Okay, and I don't mean identified, I mean as being an individual to the school district and to the personnel. So not a person with irritable bowel or a person with inflammatory bowel disease, but a patient, and then to go, oh, okay, let's see. Where does he have problems or she have problems? What can we do to help it? Let's work together to come up with a plan and then have a periodic reevaluation. So once somebody is seen and on the radar, it works.
So I know that you mentioned teams earlier between therapists and doctors and parents. Do you believe that teachers, like the teachers on day-to-day, like your English, your science, your math, should also be in on that in order to, I guess, assist them in situations where they might not be asking for help because they don't think they need it?
Right, because they don't want to be like different than anybody else.
Right.
Okay. And this also comes up with sort of HIPAA violations, the need to know and how you share information. But yes, I think that teachers can be supportive. But if you're the teacher's pet or they pay attention to you, that can backfire and then you're different than everybody else. So it really depends, again, on the individual, but the teachers can facilitate a warm and caring environment. For instance, if somebody has a social anxiety disorder and we're working on it, that may be somebody who will say to the teacher, don't call on them. Don't have them do a presentation in front of the class, okay? Let's make other accommodations. They can do it privately, they can videotape it, but something to lower their anxiety to make them be able to meet that expectation, but not under the same circumstances.
Right. And you mentioned HIPAA. What exactly is that?
Well, that's the Privacy Act that protects any medical information from anybody from going to people who have no need to know. So I can see you, or I can see another patient, and I'm not allowed to tell anybody anything unless you sign permission. Now, what's interesting about that is after 14 years of age, an individual has the rights to their own mental health control.
So they can hand out, they can tell, or...
Well, they can always tell, but they do not have to go to therapy. They do not have to take medication if they don't want to. They don't have to go to counseling. So it's another very touchy situation, because if myself and the parents see that this is an individual who needs help, but they refuse it,
I was going to say, I personally, I don't think 14 is old enough to be able to either handle your own medication or decide what you're able to take. I don't know, do you think that age is too young?
I do. I think they're very concrete. And teenagers of that age, they think that nothing applies to them individually, and you can have this sort of magical construct by what you want, you believe is true, and it doesn't apply to you what applies to other individuals. So it's a situation where, as a primary care physician, I can work with them over time, and very often they'll open up to me, and we'll talk about it, and we'll talk about what medication or what therapy will do, and how to be beneficial, and how a therapist is their best friend because they can tell them anything without having people come down on them. So sometimes it takes a little bit of time. It's not like you identify it and everything's hunky-dory.
Right. Do you see that on a regular basis?
Yes. Either that, or also parents who are very resistant. For parents' generation and for my generation, there's a huge stigma against mental health, depression, anxiety. It's seen as a character weakness and makes you less than you are. Somehow you're less of a person. So for some parents, it's extremely difficult to admit that this isn't a problem. Most of them say, well, just don't be sad. Yeah, right, they didn't think of that.
Right. And I guess that probably plays into the parent permission of the IEP, right?
Less of the IEP. For reasons that I don't know, it's much more accepting to think of an IEP and educational support. See, I'd like to think of that kind of thing as that your brain works in a different way, and that schools in general teach one way, and if that's not the way that your brain works, then you're going to have difficulty, because a learning disability means you have at least normal intelligence, and under other circumstances you would achieve. So something's holding you back. And basically, when you're in school, you're penalized by not only doing the work, but also figuring out how to do the work. And very often you're inefficient, you have to figure out another way. So that when that's much easier for parents to understand that they have two jobs, and by getting learning support, we can take away that, and they're just left with the learning. That's much more acceptable.
For whatever reason. So parents don't seem to accept medications. They seem to accept them less than the IEPs, at least.
It depends on whether there's a family history. And most often there's a family member, either one or the other, or siblings or grandparents who have struggled with mental health issues, whether they were diagnosed or not. So parents see the difficulty. But most of them do not want medication right away unless they've experienced benefit from themselves. But that's okay, that's what I want too. Right. I want them to get in therapy and then see how long it's going to come. The data shows that, at least for adults, you have equal effectiveness with cognitive behavioral therapy and with medication. The difference is that cognitive behavioral therapy takes about 6 to 8 months to kick in. That's a long time for somebody who's in the hole. And the second thing is, when you do the cognitive behavioral therapy, it depends on the mental health and the ability of the individual to be able to use those kind of skills. Because what I find is that the kids are very good at it in the office, and then when they need it, it doesn't work, right. Which is really frustrating. And it's hard for me to get a teenager to stick with it. So
if there's a hypothetical situation in which we've gone through therapy, we should be ready for medication at this point, but a parent still doesn't want it, and at that point the kid is clearly struggling. What sort of methods would you take in order to either convince the parent or show just how much the kid needs it?
Okay. They're usually aware of how much the child is struggling, but if not, I don't start with that. What I usually start with is bring it back and educate the parent as to this being a genetically based neurotransmitter or chemical imbalance. And I talk about pathways in the brain and about when you have a pathway that goes through the brain, you can have a good pathway, you can have a bad pathway. That's why you practice in sports, so that you're going to get better and better, so that if you start here, it automatically is going to go that way, because the brain will wrap that particular pathway in insulation called a myelin sheath, so it goes automatically reproducibly, which is great if it's throwing a baseball. Not so great if it's triggering off inappropriate anxiety, for instance, because the longer it goes on, the deeper it gets. So explaining what's happening, and that we can see this on electron microscope, and we know what's happening, and that if we block the pathway, it will unwrap that insulation. So sometimes backing up, and continuing to meet with them and talk about what a medication does and doesn't do, and the safety profile and all that. It's just working with them a little bit.
So let's assume that they have the accommodations, maybe they have medication. What can they do beyond just what's available to them in order to help them? So I guess, what can they do for themselves is the question.
The big thing is to take care of the basics. Sleep is a huge potentiator, meaning lack thereof. And if you look at yourself and you look at your peers around you, hardly anybody gets the 8 to 10 hours of sleep that you require as a teenager.
Yeah.
Okay? You don't need less sleep as a teenager, you get less sleep. And lack of sleep is a huge potentiator for irritability, overreactivity, mood problems, lack of concentration, memory. You know how you get on that declining slope of the learning curve if you stay up to 2 or 3 o'clock to try to finish something?
Yep.
So sleep is important. Exercise is important. Yeah. So you can't put an hour a day out. You're already strapped for time. So take the stairs when you can. Take the exercise when you can. You need sunlight, or at least I tell people to take some vitamin D, because you all are vitamin D deficient, by the way. You're indoors way too much. Eating. How many of you guys don't eat breakfast? And you need to eat breakfast, you need to get some fluids to get your hydration, get your blood supply circulating, to give some nutrients to your brain. So really, I can't emphasize how much taking care of the basics is really important.
This has been really helpful. Thank you.
Sure. Do we have a little time? I just want to mention one more thing.
Sure.
Okay. The biggest problem with this is this whole sense of self within the school and belonging to a certain group. If you have a physical disability, it's out there. So people know what they get when you're included in a group, because it's a static problem. When you are in high school, you struggle a little bit, and then you try to find like-minded individuals for something that's important for you, and that becomes the group that you become part of. So whether it's an athletic group, it's a theater group, foreign languages, you find people that you're comfortable with. And within that group, once you're accepted, this gives you a huge buffer, because within that group, you're allowed individuality. They encourage your exploration. They encourage the positive things that holds the group together. When you have a mood disturbance or something that's on the inside, nothing shows on the outside, okay? And the individual will put up this facade, this fake front, okay? Because you don't need that much to get along. Fine, how are you? Everything's fine. But behind that, they have an increasing sense of distance from what's going on. So they're struggling and they're going about life. Now you can do that for a while, but what happens is eventually their behavior changes. So they may be more quiet, they don't take pleasure in things, so they may not go out, they may be less engaging, and the group will accept that to a certain extent. But after a while, it seems odd to the group. So what they're going to do is not ask them, not sit with them. So what's going to happen is they're going to become increasingly more isolated and alone. And that really adds to the despair and the anxiety and the isolation. So what I would say is, as a student, if you see somebody whose behavior is changing, reach out to them. Okay? Reach out to them and quiet, not in the hallway, hey, what's up, dude? Take them, go someplace, do something, go for coffee, I don't really care. But just touch base and try to be there for them. I'm here for you, dude. If you want to, talk, that's fine. To have somebody that cares and is willing to take the effort to see beyond what's superficially there. I think that can be tremendously helpful.
Yes, thank you.
You're very welcome.
Thank you for being here, Dr. Gosling. I hope all of you enjoyed our show and learned a little bit more about the accommodations that are available to you in your care of physical and learning disabilities and how you can access them through your school guidance office. For more questions, ask your guidance counselor what kind of accommodations are right for you. Thank you, and we'll see you next time.